So LACNETS was founded 10 years ago, and now the acronym LACNETS stands for Learn, Advocate, Connect, Neuroendocrine Tumor Society. Earlier this year, we announced a partnership with the Carcinoid Cancer Foundation, or CCF, to provide a support line for NET patients. We will continue to deepen our partnership with CCF in the future to reach more people and to bring you more programs. So the LACNETS team also includes board members Donna Gavin in the back. So Donna is the sister of Giovanna Mbezi and Mary Dunleavy, a NET patient and NET advocate, and many other things. Lisa Yen is our Director of Programs and Outreach. And Heather Davis is our Associate Director of Advocacy and Outreach. We're also supported by our Medical Advisory Council, which is made up of NET experts, many of whom are here today. Thank you again. Thank you again for joining us to honor NET Cancer Day and to continue Giovanna's vision.
And now, with no further ado, again, someone who doesn't really need introduction because she's familiar to so many of the people here. It's now my honor to introduce Dr. Jaydira Del Rivero from the National Cancer Institute at the NIH. She's a medical oncologist and endocrinologist, and many of our patients and community know her face well thanks to her tireless efforts to provide access and extraordinary care at the NIH. And a fun fact about Dr. Del Rivero: when she's not helping the NET community, she loves to dance, and she used to be a ballerina. Welcome, Heidi.
Thank you so much for the kind introduction, and it's really my honor and pleasure to be with you all today. I do want to make a comment that everyone who is here today, all of the speakers, we really passionate about what we do. We really want to make a difference in our patients' life, everybody that we treat, but moreover, the reason why we're here is because you're our constant source of inspiration, and that's why you are our constant source of motivation. So to be able to be here is really an honor. With that, I'm just going to talk about Neuroendocrine Tumor 101. When I see a patient in clinic, I usually get a lot of questions, and that's why in order for me to address some of these questions, I may not be able to address all of the questions, but in order for me to be able to address some of the questions, the first questions that some of my patients ask is, what is a neuroendocrine tumor? Neuroendocrine tumor is an uncommon group of tumors that have a very specialized system in the sense that they have the capacity to produce peptide or hormones, and we're going to talk a little bit about that, but also arise from the neuroendocrine system. Neuroendocrine tumors can be anywhere in the body. As we can see here, we have neuroendocrine tumors that can be from the thyroid gland, from the lungs, for the GI tract, and we're going to discuss about that. But also we have neuroendocrine tumors of the skin as well, and that neuroendocrine tumor of the skin is called Merkel cell. But as I say earlier, one of the characteristics of these neuroendocrine tumors is because they have also the capacity to produce hormones that is released into the circulation, and that hormones is also responsible to produce symptoms as well. And we can discuss more about that. And not all neuroendocrine tumors are the same. They can be different also from patient to patient. They can be different in size. Some of these neuroendocrine tumors may grow faster than others as well. So another question that I get from patients is also about the classifications of neuroendocrine tumors. What is the classification? How neuroendocrine tumors are graded? What are the stages of neuroendocrine tumors? And just briefly, we're just going to discuss that. As we discussed, neuroendocrine tumors can be anywhere in the body, but we can see that it's more commonly found in the GI tract and the pancreas. Some of the questions that I also get from patients was like, what staging mean? A staging is a way to describe where the cancer is located where it has spread, or whether it's affecting other parts of the body. And I don't want to go into details about the different stages, because also between different neuroendocrine tumors may be a variation of stages based on the location and what other organs may affect. But usually stage 1 is when the neuroendocrine tumor is localized, it's small. Stage 2, the neuroendocrine tumor may be a little bit larger, but not necessarily has spread, doesn't spread to the lymph node. Stage 3 is when the neuroendocrine tumor could be of any size, but it also has spreads to some of the lymph nodes nearby and maybe some of the organs nearby. And stage 4 is when the neuroendocrine tumors has distant metastasis, so it has spread to other part of the body. But that said, even between different neuroendocrine tumors may be also variations of stages as well. Now, what is the grade and differentiations of neuroendocrine tumors? And I'm sure you have heard a lot about these, and you have learned a lot about that as well. Between neuroendocrine tumors, we have low-grade neuroendocrine tumors where the cells are divided at a low rate, and because of that, they're very slow-growing. Intermediate grade is when the cells are at intermediate rate of growing as well, and the high grade is when the cells are able to divide more quickly. Another way that we're able to also differentiate between the low grade, intermediate grade, and the high grade is this number that we always look and ask for, which is a Ki67. So the Ki67 tells me how the cells are able to divide under the microscope, but it's a number that a lot of the pathologists are given for that. And if it's low grade, the Ki67 is less than 3%. Intermediate grade, the Ki67 is anywhere from 3 to 20%. And the high grade is when the Ki67 is greater than 20%. But I also want to make a difference even with the grade 3. We have a grade 3 well-differentiated neuroendocrine tumor, and we have a grade 3 neuroendocrine carcinoma. And there's a difference in that as well. And that's what we're going to discuss about this. So this is kind of like the summary on what the different grade of progressions and the different grades of neuroendocrine tumors as well. One thing that you will hear a lot today is about the DOTA skin, 68 gallium or 64 copper DOTA skins. Patients that are well differentiated neuroendocrine tumors may express this receptor in the surface of the tumor cell, and that's the reason why this is a very good diagnostic tool as well. And as we discussed earlier, there is a well-differentiated grade 3 neuroendocrine tumor, but usually in terms of the numbers, is less than 55%. I don't know if there is something that we need to learn about the numbers, but the importance about this slide is that we need to differentiate between well-differentiated neuroendocrine tumors as well as neuroendocrine carcinoma, because they're different in terms of how they behave, and of course the treatments are different as well. Now, what are the symptoms related to neuroendocrine tumors? And there'll be a variety of symptoms. And one thing about neuroendocrine tumors, by the time they're diagnosed, they're already in advanced stages because they have very non-specific symptoms. And that's where we're going to discuss between functional or non-functional neuroendocrine tumors, and discuss as well what is the difference between the two of them. If there is a functional neuroendocrine tumors, meaning if the tumor is producing hormones, we have a series of symptoms. But if a non-functional is, they may have non-specific symptoms, and most of the time these tumors may be diagnosed more like irritable bowel syndrome. But that said, some of these symptoms may also mimic very different disorders, and that's why when the patient is diagnosed with these neuroendocrine tumors, can often be diagnosed in advanced stages too. And that's one of the efforts that we're trying to, at least in the research aspect, is what we can do in order to diagnose neuroendocrine tumors earlier. Depending on where the tumor is located too, they can also cause some bleeding too. They can also have a lot of abdominal pain, weight loss, fatigue. Also, depending on where the tumors are located, they can cause bowel obstruction. Dr. Carrington will discuss more in detail as well, and the indication of surgery too. But one thing, like I mentioned here, is because this mimic a variety of other medical conditions, there is a delay in diagnosis, and 80% of patients with neuroendocrine tumors may be misdiagnosed with irritable bowel syndrome. Now, what is the difference between functional versus non-functional neuroendocrine tumors? Neuroendocrine tumors may be functional, as I discussed earlier, because they have the capacity to produce excess of hormones, and this excess of hormones can produce specific symptoms depending on what hormones the neuroendocrine tumor is producing. But they can also be non-functional neuroendocrine tumors, meaning that they don't produce hormones or not enough of the hormones to cause any symptoms. So this is another representation about what I said earlier, the neuroendocrine tumors can be anywhere in the body. And when I talk to my fellow, one of the things I always discuss to my fellow is that in terms of the neuroendocrine tumors, if the tumor is functional, if it's producing hormones, I ask what do we need to do in order to improve the symptoms related to the excess of hormones. Because regardless of what we treat in the patient with neuroendocrine tumors in terms of different systemic therapies, a lot of these neuroendocrine tumors, we need to do other interventions in order to minimize the symptoms related to hormone excess. And as we can see, depending on where the tumor is located, whether it's the lungs or whether it's the pancreas or the small intestine, they also may produce different hormones. Now, in terms of the pancreas neuroendocrine tumors, most of the time they're non-functional, meaning they don't produce hormones, but up to 40%, 30 to 40% may produce hormones as well. These are the different hormones that they produce, and based on what hormones they produce, they may have specific symptoms. And that's where this slide is telling you as well, too. So these are the different tumor types that are the most functional that can cause symptoms. Small bowel neuroendocrine tumors are the ones that may produce serotonin. And this serotonin we measured in the urine in the weight of 5-HIAA. These are the responsible for these symptoms related to carcinoid syndrome, and those are the different symptoms as well. Insulinoma is functional pancreas neuroendocrine tumors. The excess of insulin lowers the glucose level, so a lot of patients have very severe symptoms related to low glucose. These are not very common. Like I said, most of the time the pancreas neuroendocrine tumors are not functional, but depending on what hormones they produce, they may have different symptoms as well. For example, gastrin is another one. Gastrin also is responsible for the excess of acid in the stomach, and this excess of acid in the stomach can also be responsible for ulcers, bleeding. So those are the same symptoms that we need to look for. This is just some of the findings. Since this is neuroendocrine tumor 101, we're not going to go into details because you're going to hear more of this throughout the day. But if you have any questions, please don't hesitate to contact me, talk to me throughout the day. Now, as I said earlier, there are the different management depending on what the neuroendocrine tumor hormones it produce, and based on what the symptoms are, they need to have different measurements as well. So what I wanted to take from this slide is that we know the different therapies for neuroendocrine tumors that you're going to hear throughout the day, like 177 addition dotatate. You're going to hear about the everolimus. You're going to hear about sunitinib and other drugs throughout the day. But something that that we also need to keep in mind, especially for functional neuroendocrine tumors, is that there's different measures that we need to address as well. And that's kind of like the things that we need to discuss with our physician, what we can do in order to address the symptoms related to hormone excess. So what are the symptoms related to carcinoid syndrome? So as we discussed earlier, the symptoms related to the symptoms related to carcinoid syndrome most commonly is flushing, diarrhea. These symptoms can be quite debilitating as well. And as I mentioned earlier, in terms of the management of the hormone excess or serotonin excess, we need to also give different measurements in order to control the diarrhea. One of the most common treatments in order to control the diarrhea is the monthly injections, either lanreotide or octreotide, long-acting octreotide. Something to keep in mind about those injections is like it can have effect on controlling the growth of the tumors, but it can also have an effect on helping control the symptoms related to the excess hormone. And thus, like I said, these symptoms can be quite debilitating. One important aspect that we need to recognize about carcinoid syndrome is that this excess of serotonin can also affect the heart valve. It can cause like scar tissue of the heart valve. So patients that have this excess of serotonin or elevated 5-HIAA, we also recommend seeing a cardiologist as well, so that way they can have an echocardiogram to look for any abnormalities on the heart valve. But as we can see, there's different symptoms that can be associated with the carcinoid syndrome. And like I said earlier, the things that we need to do in terms of control the there are different measurements that we need to implement in order to control the symptoms related to the hormone excess, as we discussed with the lanreotide or octreotide. And that's an important, I'm sure a lot of you are familiar with this and how often they're given. Sometimes in patients that they still have excess of, still having symptoms related to diarrhea, despite having it every 4 weeks of lanreotide. Sometimes we recommend giving it every 3 weeks instead of 4 weeks to minimize, to see if maybe that can help some of the symptoms. There are other things that we can implement as well or recommend in those situations, like the lotristat. We know that the lotristat is a medication that blocks the excess of serotonin. Maybe throughout the day you'll hear more about that too, but if you have any questions, please ask me as well. This is something that is very important to mention. LACNet has been doing a lot of work on this, and in order to facilitate the knowledge of neuroendocrine tumors, not among patients, but also among providers. I have to acknowledge Dr. Danley was also worked together or collaborated together with LACNet to develop what we call is the Net Vitals. And the Net Vitals is a very important information for neuroendocrine tumors so that provider can learn about the most important clinical findings related to the neuroendocrine tumors as well. And also, this is an information that is given also to primary care physicians. This is an information that can be also to learn about your neuroendocrine tumor as well. Another tool that is important is that LACNet has is a net interest, like your elevator speech, how you're able to speak about neuroendocrine tumors to somebody who you want to talk about neuroendocrine tumors. These are very important tools that I think is important that you acknowledge, and they're available here as well to understand, to learn more about neuroendocrine tumors and how to communicate that with providers, because as we know, not every physician in the community may know about neuroendocrine tumors, and sometimes patients are the ones who teach our providers as well that are not familiar with neuroendocrine tumors, and that's, I think, important to acknowledge as well. So another question that I also get is like, what are the genetic syndromes associated with neuroendocrine tumors? And up to 10%, 10 to 20% of patients with neuroendocrine tumors may be associated with an inherited syndrome. One of the most common one is MEN1, and we will discuss what are the clinical findings of MEN1. Another one is von Hippel-Lando, neurofibromatosis, and another one less common, very uncommon, super rare, is a condition called tuberous sclerosis. As Lisa mentioned earlier, whoever is here is a patient with pheochromocytomas and paraganglioma. This is also a rare type of neuroendocrine tumors, but in PheoPara, up to 45% of patients with pheochromocytomas and paragangliomas may have a mutation that may be associated with familial syndromes, or what we call a germline pathogenic variant. So in every patient with pheochromocytomas and paragangliomas, every single patient needs to seek a genetic counselor. It's not necessarily like that for neuroendocrine tumors, but we always, in somebody who is young and presentation, we also look for these findings to see if there's maybe any cancer predisposition syndrome associated with the neuroendocrine tumors. And this is just a cartoon that tells you like the different mutations that can be associated with neuroendocrine tumors too. With the like medullary thyroid cancer, there's another condition called MEN2. We're not going to discuss this today, but the ones that we're going to discuss is the ones that are associated with the GI and pancreas neuroendocrine tumors. And those are the familial syndromes. One of them is MEN1. The clinical characteristics of MEN1 is primary hyperpara. So in the thyroid gland, we have a very, very tiny glands that is the size of a rice. Those are called the parathyroid glands, and those are responsible to regulate the calcium in the body. This MEN1 also has gastric and pancreas neuroendocrine tumors, but what we know about MEN1, it can also be associated with lung neuroendocrine tumors and other neuroendocrine tumors in other part of the body, as well as pituitary tumors. Von Hippel-Lando is the most common clinical manifestations is what we call these central nervous system hemangioblastomas. They're tumors arising from blood vessels, as well as kidney tumors, and also gastric and pancreas neuroendocrine tumors has been associated with von Hippel-Lindau, mainly pancreas neuroendocrine tumors. Most of the pancreas neuroendocrine tumors associated with the VHL, they're not functional, but they can be quite large, and that's something that we need to acknowledge about von Hippel-Lindau. And these are neurofibromatosis and tuberous sclerosis, even more rare, but they're also neuroendocrine tumors has been associated with these conditions. That said, if you ask me, do I have this? Usually, before the neuroendocrine tumor may be evident, there is other clinical characteristics associated with these neuroendocrine tumors. Like I say, it's a series of clinical manifestations associated with this, and usually there is other tumors or other clinical manifestations before we can see the neuroendocrine tumor. So it doesn't mean that you may have one of these. It's just one of the things that we look in a patient that is relatively young. So those are the things that we look as well. If we have a patient that has a pituitary tumor and a neuroendocrine tumors, then we could suspect that this patient may have an MEN1, and then we can then guide what would be the best follow-up in terms of genetic counseling after that. So what are the diagnostic studies for neuroendocrine tumors? Biopsy, that's a way that we can diagnose a neuroendocrine tumors. This is a tissue that is examined under the microscope. We have different blood and urine tests. The urine test is like I said, the 5-IAA. We have CT scans and MRI that help us to understand how the tumors are, the size of the tumor, and in relationship with the other organs as well, and nuclear medicine imaging. And you're going to hear a lot today about DOTA scan, 60 gallium and 64 copper DOTA scan. Since I'm running out of time, I just want to make sure that you have an excellent Dr. Auerbach, who will discuss more about the different imaging modalities and DOTA scans. But just to mention here, DOTA scan is the most sensitive scan. This is in the past. We used to use a nocturnal scan, but we don't use this anymore. If your doctor is recommending a nocturnal scan, say no, because we have much better imaging studies with the copper and 60 gallium DOTA scan. And the last thing that I want to mention is about when neuroendocrine tumors is advanced of metastatic, what are the treatments available, and Dr. Datlin will discuss more in detail about that. I always said that, before 2000, we didn't have that many treatment options, but now in the last 2 decades, we can see that we have various treatments available. Sometimes the question is about sequencing, meaning when we have a patient with neuroendocrine tumors, what do we do and what we recommend as a first line and so forth. But that also depends on the clinical characteristics of the neuroendocrine tumors based on where the neuroendocrine tumor is located, whether it's only in the liver or also outside the liver. We also discuss about it's important to know where the primary neuroendocrine tumor is, whether it's the pancreas or small bowel. We discussed about grading earlier, so that's important as well, whether it's well differentiated or poorly differentiated. We discuss about functional status, whether it produces hormone or not. And then we'll hear a lot more today about the expression of somatostatin receptor as well. So all of that needs to take into account in order to provide the different treatment modalities available for neuroendocrine tumors. And as we can see, we have quite a few tools within our toolbox, but then in order to determine what is the best treatment options, we need to account for all those patients' characteristics. And with that, I just wanted to finish with my take-home homes that neuroendocrine tumors are heterogeneous. It's different from patient to patient. We usually recommend that a multidisciplinary team is necessary in order to discuss a patient with neuroendocrine tumors to determine what would be the best treatment algorithm for our patients. As I discussed, it's important to understand the primary tumor site, the differentiation, the grade, the functional status, as well as whether the tumor expresses somatostatin receptor or not. Up to 30% of pancreas neuroendocrine tumors may produce hormones, and because of that, they have very specific symptoms. And GI neuroendocrine tumors, small bowel neuroendocrine tumors may develop carcinoid syndrome. We have different tools, as I discussed, and Dr. Lin will discuss more in detail on when we can use those tools. And of course, tailoring treatment for every patient requires a careful balance of patient and treatment characteristics. And with that, I would like to thank you all. I always like to say this: individually we're a drop, but together we're an ocean. So I really thank you for your attention.